the failure of medicine in the US to properly treat chronic conditions. We've been very good at treating acute conditions. Somebody gets in a car accident and they get crushed. Somebody gets shot. We're great.
And then as soon as they're like awake and extubated, it's like you're out of the ICU, then you're in the step down, and then in a couple of days you're sent home.
Yes.
So you literally go from intubated, asleep, in an ICU, can't move, can't breathe, to being home in a week.
We solved the emergency.
And then you're forgotten.
Yeah, that's right. We've got so many people right now headed into, the baby boomers was this huge population of people that are now headed into their older years. And now they're headed down this path of fighting the chronic disease, fighting the chronic pain, fighting arthritis. Diabetes has been such a problem with that age group, and it's only getting bigger. It's something that we're gonna have to get way better at, and I think that neuromodulation offers some great potential solutions for those conditions. I wanna touch on another thing in neuromodulation. Obviously there's spinal cord stimulator, which we've touched on. There's PNS, there's DRG. Can you tell everybody a little bit about the similarities and differences in application for those?
Sure. So I think there are individual applications for each. I think of PNS as treating, it says peripheral nerve stimulator, treating more of a peripheral nerve problem. You think about like a carpal tunnel, okay? Or that's a peripheral nerve entrapment. You can get a peroneal nerve injury in your foot or leg. They're more like an isolated type problem. I think of PNS and DRG as treating a more isolated type problem versus spinal cord stimulator as maybe a little bit more of a global problem. They're a little more focused and targeted. DRG is really cool, especially for CRPS, and that's complex regional pain syndrome, and that's usually after some sort of injury or surgery or trauma where you get these sympathetic changes in the extremity, so very sensitive, the things that shouldn't be painful, like I can't wear my sock in my shoe. These patients will come in winter wearing sandals and flip-flops. They're like, I can't wear a shoe. There's an interesting study called the ACURATE study that compared DRG to traditional spinal cord stimulations for the treatment of CRPS, showing non-inferiority and superiority for DRG for CRPS symptoms. I think it's a great therapy, and I actually think that it treats CRPS at the problem, which is the DRG. And this is maybe a little bit too nerdy, but there's something there called a wide dynamic range neuron. It's like a relay station for the nerve signals that come from the extremity to your central nervous system. And what we know happens there is that can kind of switch over from being a non-painful signal to being a painful signal, and it typically happens at that DRG. So what's so great about using the DRG stimulation is you're really focusing at the level where the problem occurs.
Specific.
Very specific.
Versus I would say spinal cord stimulator is more shotgun approach.
Yes.
You're stimulating the entire spinal cord.
Correct.
And it's going to shut off pain.
Correct.
So I think it's...
So DRG is a focal thing. Like I had the CRPS, I had a great conversation with a lady and kind of explained this to her on the phone this morning who's scheduled for a DRG trial, and it's all in her foot after a foot injury. I think of PNS, again, as being a little bit more focal. PNS, you really have to, you're really focused on targeting an individual nerve, okay? DRG is focused on more a spinal nerve or a nerve root, which is a little bit more broad.
So PNS, we're talking about like shoulders.
It can be used for orthopedic applications. Where we've had a lot of success in the past is like orthopedic knee and shoulder pain. Okay. That's not necessarily neuropathic. You can use it for either, but I think that is a unique application of PNS. We'll see a lot of patients who are like, I have this terrible shoulder, I don't want a shoulder replacement. Or maybe they've had one and they still have problems. And so we can use a PNS stimulator to target the suprascapular nerve and to stimulate that nerve to provide relief. And we've had a lot of success doing that. Same with knees. We have patients who don't want to have a knee replacement or have had one and still have problems. And Very similar process to the stimulators that we discussed earlier, where you get to do a trial first. Difference with those is it's a very superficial placement typically, instead of something that's deeper in the spinal canal. There might be a little bit different safety margin there, which might be appealing to someone. But again, a great therapy. You get to trial it out first and see how much it helps you, and then the implant for those is again pretty simple procedure that's about 45 minutes to an hour, depending on the location. And I think people are having great success from these chronic issues that they have that there's not another answer for.
One other procedure that I want to touch on that is unique to us in this area, and that I think is going to gain in popularity really rapidly, is Intracept. It's obviously something that you have to be very skilled and learn how to do. It's something that we can help other providers learn how to do and bring back to their areas, as we've done with other procedures in the past. And
interesting point. Surgeons are actually having people do this procedure before they do a fusion.
Doesn't that make
cool.
sense? I think that's amazing.
Makes a ton of sense.
So, okay, so I want to touch on a couple other things before I let you go, and this has been super informative, and I hope people really find value out of this, because we did some deep dives into the science and things like that. Tell me a little bit about some of the frustrations that you run into with insurances, and sometimes with compliance, with getting patients from when they come in the door to through the procedure, so that we can get them the result.
Yeah, I mean, I think people want an immediate solution and fix, right? Yeah. And my response is always, you didn't get in this condition overnight. Right. You know, it's usually not something that you just snapped your fingers. This has been a degenerative process over years. You may have more than one problem that we're trying to solve. Right. Just know that we are working on all of them for you. I typically will tell patients, like, what's your number one complaint? And people are like, well, everything. I'm like, well, we can't fix everything. And insurance won't let us fix everything all at once.
It's true.
I can't order an MRI of your entire spine. It's going to get denied. I have to order a focused MRI on one area and let that guide the therapies. And so it's like, just be patient. Let us work our process. I know it's frustrating. Trust me, we are working our quickest to get this stuff done for you. We have an entire team behind the scenes who are doing your insurance legwork, who are calling the hospitals and MRI facilities, who are calling the labs to get the lab work done. Like, we have a whole team dedicated to making sure that this gets done as quick as possible for you. So that's my number one, I think, advice to patients, and maybe patient is like, I know that there's a lot that you want to get done. We're going to get it. We can only really work on one thing at a time. And that also kind of goes back to insurance. Like, I'm kind of handcuffed with what I can and can't do because of insurance. But I also and insurance isn't always the bad guy. Like, I understand that. Like, I do. I understand.
They're not always the bad guy.
Not all. Yeah, but I understand too that, like, I just can't order a zillion things and get them all done. Like, I need to have some.
You got to follow the guidelines.
I need some sort of plan in terms of how sequentially I'm going to help this patient. And I just wish that I could present that plan. And if I needed to get a cervical and lumbar MRI, the patient could get them both done while they're at the MRI place and save them a couple of trips and a couple of copays. Like, that would be nice, right?
Absolutely.
Instead of like, okay, I can get your lumbar, and now we have to wait like 3 months and go back and get your cervical MRI or whatever. I think my biggest, I think, barrier with insurance is just kind of like, it changes all the time, and they change all these requirements, and they're supposed to follow Medicare guidelines, and they don't. And
Medicare, I feel like, has gotten pretty sane, and a lot of their guidelines, they've gotten pretty reasonable, and they're sort of the golden rule in terms of what you would expect other companies to follow.
But they don't always follow that, and they just feel like we're too big to follow the rules. We can kind of do whatever we want without any recourse. And like, so here's an example. We'll get a denial for a procedure, and they'll want us to do a PA. Well, as soon as we initiate the appeal, as soon as we initiate the appeal, they say, oh, it's approved now. And it's like, well, why did you make us?
They just wanted to see if you were going to do the extra.
Exactly. And it's like, it's just kind of silly. It's like you're playing a game. Playing a game, and I've said in the past that I feel like there's just like every day of the week there's like a different stamp. Everybody with the last name starts with T, denied, stamp, denied, denied.
I think unfortunately, there's a difference, and people need to recognize this. Obviously, your doctor wants to help you.
Yeah.
We have all kinds of tools to do that and to get somebody relief. We are bound to follow the guidelines as a practice, and we do our best to do that. And we, like you said, we've got an entire team that's very efficient to get them to that point. But
I would dare say we're way more efficient than anybody else in the area.
it is. We have an incredible team, and they are very smart. They're very dedicated and know what they're doing.
And even people's individual insurances have different requirements too.
Yes.
Like I recently did an appeal with a very understanding orthopedic surgeon for a stimulator for a patient who's fused from L1 to S1. Why on earth anyone would have a bigger surgery is beyond me, but the insurance plan requires that he be seen by a surgeon first to make sure that there's no other surgeries that are warranted before we do a stimulator. It's like, this guy's already fused his entire lumbar, is fused to his sacrum. Like, what is a that's fine. But then they also wanted me to get imaging of his lumbar. The lumbar that's already fused and shouldn't be moving or having problems, like,
right.
At some point, we have to have some sort of reasonability and sanity. And the orthopedic surgeon said, look, I understand, I agree, it's silly. But he's like, this is just what the plan dictates. And so we have to follow that. So now our guy's going to get more imaging and an unnecessary appointment with an orthopedic surgeon, which all costs the insurance company more money. But that's what their own thing, and delays care for our patient. But that's what they dictate.
That's the biggest thing is trying to, obviously we do our best to try to mitigate those delays that are caused by insurance, and it can be very frustrating.
Well, and this patient has already been through so much, and it's like we're just
suffering every day.
It's a month to get in to see the surgeon. It's a month to get your CT scan. It'd be different if I could pull the trigger and make those things happen immediately, but this person is just getting worse.
Well, and one of my
conditioned, and
it's tough, and one of my biggest frustrations, especially here in Ohio, having done medical practices over in Indiana before and in Florida, and there's different states, and different states have different rules, especially when it comes to Medicaid. Mm-hmm. And it's like there have been so many advances in minimally invasive procedures that we do, and interventional pain, and solutions to things like the opioid epidemic. But when you've got a system that doesn't reimburse at least on par with Medicare, which is the standard. So if they're going to reimburse down here, it actually costs us money as a practice. We can't even pay our own staff if we're going to do those procedures.
There's certain things that we just can't do for Medicaid patients because we lose money, and if we can't pay our staff, we can't.
Yeah, I mean, you can do some pro bono cases, but it's also like, if you want to talk about a systemic problem in the state of Ohio that needs change, it's Medicaid.
Yeah. Well, it's almost like there's a two-tiered system. It's like, why don't they get the same opportunity at a therapy or an intervention or a treatment as someone who has better insurance?
It's a very bizarre thing, and some of these states, such as Ohio, might, somebody at the top, like the governor, might want to get interested in why there has been an opioid epidemic created.
Yeah.
It's pretty simple math, in my opinion.
Yeah.
And so if they want change, they want long-term change.
Are you saying that Medicaid pays for narcotics and opiate medicines and they don't pay for
interventional procedures?
Yeah.
Yeah. And it's been that way for decades.
Yeah.
And so, I think that the laws and the policies haven't caught up with the advancements that have been made in medicine. And so somebody needs to correct that. Yeah. And I think once it gets corrected, boy, we have a huge opportunity to help so many more people.
Yeah.
And that's what I'm looking forward to. And hopefully my push with the Ohio government can make some
something to be
there.
passionate about for sure, and something that could help a lot of people who otherwise don't get help, who are great people who have lives just like the rest of us do.
And they deserve to have the same standard of care.
I 100% agree with you. And it is sad that insurances will support a narcotic prescription more so than they would support an actual permanent type treatment.
Well, and it's not that narcotics aren't warranted. I mean, obviously they are warranted in a lot of
There's
cases.
a lot of people who need them.
Of course. But when you've got other procedures that long term can affect a much larger change, I think it's...
Well, and narcotics shouldn't be the first option and the most easily accessible option, right?
Correct.
Well, that goes back to what I'm saying. My mission is like, let's get the word out about all of these interventional procedures. Let's get the word out about how safe they are, about how effective they are, about how they can change people's lives without a pill, and let's make them more accessible too. Let's join forces there.
We've got to change. We've got to make some change, and we've got to keep doing what we're doing and getting the word out.